Dear colleagues, thank you very much for this great opportunity for me to present the new 2023 ACR EULAR classification criteria for antiphospholipid syndrome. My name is Stéphane ZUILY. I'm a professor of vascular medicine in Nancy University Hospital, and I was pleased to be the co-PI for EULAR regarding this new criteria together with Doruk Arkan in Cornell University Hospital for Special Surgery, the co-PI for ACR, and together with Meda Barbaya, we had the privilege to lead these international efforts. So here are my disclosures, not related to this talk. So you know that APS is more than we think. APS was defined based on classification criteria published in 1999, Sapporo criteria, and then further updated during the Sydney criteria, published in 2006. And APS was defined by thrombosis or obstetrical morbidity in patients with antiphospholipid antibody. But every day we know that some manifestation can be associated with this syndrome. And we all know that the spectrum of the disease is very wide, with arterial and venous thrombosis, pregnancy morbidity, non-criteria manifestations, the well-known catastrophic antiphospholipid syndrome, all microvascular with small vessel involvement, and also we have patients with antiphospholipid antibodies, but without any manifestation that we cannot classify as APS. This very wide clinical spectrum that we have to deal with is very important, and our goal, our quest, was to update the previous classification criteria to a new set of criteria involving a clear definition and a clear classification of this syndrome. And if we can summarize the limitations of the current APS classification published in 2006, we could say that the representation of heterogeneous manifestations are not involved as classification criteria, such as livedo reticularis, thrombocytopenia, heart valve disease, and so on. Second point is that we do not stratify the classification based on risk factors or based on APL tests. And third, some definitions could be improved in order to classify patients with the same kind of clinical manifestations. So first, I would like to stress that classification and diagnosis criteria are completely different, and the goal is different. First, the goal of classification criteria is to define study sample representative of the majority of patients. We do not want to catch the entire world of patients with APL positivity. Second, our goal is to catch homogeneous groups of patients with the majority of manifestation that can be seen in patients with antiphospholipid antibodies. We do not want heterogeneous groups in order to do research. Third, there is no impact on billing or reimbursement. And fourth, the impact on treatment could be different. Classification criteria are devoted to research, while diagnosis criteria is for diagnosis and patient care. So these classification criteria were made to identify homogeneous groups of patients with the majority of manifestations for research, and the goal and the demand from the ACR and EULAR was to create specific criteria. So to summarize, I could say that our quest was to determine for research highly specific criteria to identify homogeneous groups of patients with a high likelihood of having APS, high specificity. So first, to begin, I would like to compare two clinical scenarios, and I would like to ask you the question, which patients has the highest likelihood of having APS? First clinical scenario, a male, 48-year-old, with very high risk cardiovascular profile, high BMI, high blood pressure, dyslipidemia. This patient presents an ischemic stroke and you discover an APL profile with lupus anticoagulant and IgG anti-beta 2 GP1 90 GPL. And if I compare this patient to another patient with a different APL profile, I would say IgM anti-beta 2 GP1 29 with the manufacturer threshold of 20, the IgM is positive, but lower than the first patient's. Which patient has the highest probability, likelihood of having APS? I would say the patient on your left-hand side, and then you can understand that depending on the APL profile, the likelihood of APS could be different. Second case scenario, the same patient, male, 48-year-old, BMI, high blood pressure, dyslipidemia, ischemic stroke. But you compare this patient to another patient without any cardiovascular risk factors. Which patients could have the highest likelihood of having APS? I would say the patient on your right-hand side, the patient without any risk factors. And then you can understand that the presence or the absence of risk factors could have an impact on the likelihood of having APS. Third case scenario, the same patient with ischemic stroke, but you compare this patient to another patient with several manifestations. The second patient has a history of ischemic stroke, but also a history of pulmonary embolism and Lehmann-Sachs endocarditis. Which patient has a highly likelihood of having APS? I would say the second one, with several manifestations. And then you can understand that depending on the number of manifestations, there is an additive value, and the higher the number of manifestations, the higher likelihood of having APS. Then we can summarize that different factors could impact your judgment to classify your patient with APS. APL profile, risk factors, and the number of manifestations. So how did we handle this issue? We handle this issue in order to improve the current APS classification criteria. And first, in order to do that, we try to understand what was APS and to perform different meta-analysis in order to first identify which manifestation is clearly associated with antiphospholipid antibodies, and second, what are the magnitude of the risk depending on the APL profile. On this table, you can see different things. First, you can see that in the green boxes, these green boxes correspond to a significant association between APL profile and the manifestation. You can identify that valve disease, pulmonary hypertension, livedo reticularis, APS nephropathy, thrombocytopenia, or hemolytic anemia were clearly significantly associated with antiphospholipid antibody. And the second thing that you can see is that depending on the APL profile, this association could vary. The clear association was confirmed with IgG anticardiolipid antibodies and lupus anticoagulant, while for IgM or anti-beta 2 it was not so clear, except for hematologic manifestations such as thrombocytopenia or hemolytic anemia. We performed several analyses in order to identify the impact of the APL profile. We did dedicated task force, literature reviews, Delphi consensus, and specific analysis such as this one, based on 1,000 patients, and we identified the role of the additive value of IgM antibodies compared with traditional IgG and lupus anticoagulant. And we found that IgM for thrombosis did not add anything to the classification. And to finalize this first part of my presentation, we tried to improve the definition of each criterion. I would take the example of heart valve disease. Before, the heart valve disease, and especially the thickening of the heart valve disease, was defined above 3 mm of thickness. And we, based on the literature review and several analyses, we identified that this threshold was not enough specific because all patients with APL positivity had a thickness between 3 to 5. So do you think that all patients with APL have a heart valve disease? I'm not sure. That's why a higher threshold could be more specific in order to identify those with a clear valve thickness. And it was our first goal. And the definition of heart valve disease for the thickness is different now with a higher threshold in order to be more specific. Finally, we applied the ACR EULAR methodology in order to identify the clear criteria associated with APL positivity. First, we did the phase 1 item generation. We generate items in order to be sure that all the spectrum of manifestation were identified. Then we reduced this number because, of course, all manifestation could not be included as new classification criteria. We further reduced the number of items, we weighted them, and then we validated all items that we were sure that the specificity was higher. And then we were able to obtain classification criteria set, such as the one for systemic lupus erythematosus. If you can remember, you have different items with different weights, and depending on the additive value and the addition of all these weights, you can obtain a total score. And if the total score is above the threshold, then you can conclude that the patient can be classified as having SLE. We did exactly the same, and we applied that to the world of APS. So now I'm going to present the different details based on the new classification criteria for APS. I would like to again thank a lot my colleagues and friends Doru Karkan and Meda Barbaya. And here are how it works. First, the first step for this new classification criteria is to answer to a first question. Does my patient can fulfill the criteria of the entry criteria? What is the entry criteria? The entry criteria is a mandatory step that can allow you to test the classification criteria and to apply the classification criteria to your patients. If your patients do not fulfill this first mandatory criteria, you cannot go further. So this entry criteria is at least one documented clinical criterion based on all the different domains that I will present in a couple of minutes, plus a positive APL test, whatever the test, above a moderate to high titer. Within 3 years, the delay between the identification of APL positivity to the clinical manifestation should be within 3 years, not more. Second step, clinical domains. You will see different domains, different manifestations, and you will add points regarding the weight of each manifestations, and the higher the score, the higher the likelihood of APS. In this clinical domain, you will see that we were able to introduce risk stratification based on the presence of risk factors or based on the number of manifestations, which is something which is very important. Do not count a criterion if there is an equally or more likely explanation than APS for this manifestation. I could take the example of thrombocytopenia. If a patient has a chemotherapy and then during the following days the patient presents a thrombocytopenia, perhaps due to chemotherapy, are you sure that you could count thrombocytopenia associated with APL positivity, while chemotherapy could be a clear differential diagnosis? So if you have an equally or more likely explanation, do not count this criteria. Second important thing, within each domain, only count the highest weighted criterion towards the total score. If you have the choice between 1 or 3 points, do not add this within the same domain. Use only the one with the highest score. Third step, lab domain. Same story, only the highest score. And then you will obtain 2 scores. The number of points for the clinical domains and the number of points for laboratory domains. If you have 3 points of more within the clinical domains and 3 points of more within the laboratory domains, then you can classify your patient as having APS. So now I'm going to give you the details regarding the different domains. First domains, macrovascular domains with venous thromboembolism and arterial thrombosis. And you can see here then that you can stratify based on risk factor. There is a clear definition how to stratify a patient with a high-risk VTE profile or a high-risk cardiovascular profile in the publication. And depending on the profile of your patient, then you will be able to add the appropriate number of points. Second domain, microvascular domains with new manifestations such as livedo-racemosa, livedoid vasculopathy lesions, or pulmonary hemorrhage, adrenal hemorrhage, or also microvascular impairment, cardiac impairment based on MRI data, which are very important. And then all these new criteria now are parts of the classification criteria set in the 2023 ACR EULAR. There is two different steps. First step, do you think that this criterion is suspected? Second step, do you think that this criterion is confirmed or established? The higher probability of being sure that this criterion is present in your patient, the higher number of points you will obtain. Fourth domain, obstetrical domain, with different manifestations, and you will see that the criterion that is associated with the highest number of points is the very highly specific criterion, such as preeclampsia patients with placental insufficiency, with severe features, and without fetal death. Then we added two new domains, cardiac valve domain with thickening or vegetation, and thrombocytopenia domain in the hematology domain, with thrombocytopenia, which is clear manifestation seen in APS patients. And then there is one of the last steps, which is the step in the laboratory domain with two different domains. First domain, lupus anticoagulant domain, and second domain, ELISA test based on anticardiolipid antibodies or anti-beta-2-GP1, RGG or IgM, and you will see that depending on the APA profile, you will have different score, which is clearly associated with the likelihood of having APS. I would like to stress that these results are based on ELISA, not new automated platform, and a clear efforts is ongoing to identify which threshold are similar based on different platform, ELISA versus automated platforms. Then these new criteria are clearly more specific than the previous one. You can see here that the specificity is improved compared with the old criteria, the Sydney criteria, with almost 0.99 specificity in this new criteria. This was the goal of the creation of these new ACR EULAR criteria. And then I would like to finish in a few minutes with the same clinical scenario to show you how to classify your patient, how to use the classification criteria set. This first situation, male 48-year-old, no risk factor, ischemic stroke with different APL profile. You can see now that this patient could have different points. The patient on your left-hand side could fulfill the APS classification criteria threshold, 3 points in each domain, while the patient on your right-hand side do not fulfill this classification criteria. Second situation, based on the presence of risk factors, the patient on your left has a provoked pulmonary embolism based on the presence of an active cancer, while the patient on your right-hand side has a spontaneous, idiopathic, or unprovoked pulmonary embolism that could, of course, impact the likelihood of having APS and could be classified as having APS. Third situation, based on the number of clinical manifestations, you can see that the patient with ischemic stroke, pulmonary embolism, and Lehmann-Sachs endocarditis has a higher number of points that could be over the threshold and then classify your patients. So I totally agree if you say to me that these new classification criteria are more specific but could be disappointing and perhaps difficult to handle and to use in everyday practice. And we could understand completely based on the difference with Sydney criteria. We already prepared online calculator which could be very useful for you on everyday practice, and don't hesitate to log on this website and use the online calculator that could be of course very useful in your everyday practice. In order to conclude, I would say that the new 2023 ACR EULAR classification criteria for APS were designed in order to improve the old one. They are not perfect, but we will be able to improve them again and to update them in the future. They could be able to include heterogeneous manifestations not included so far. We can now stratify on different things, risk factors, but also APL test, and there is now a clear definition of each criterion. And these new criteria were developed using rigorous ACR EULAR methodology with a clear multidisciplinary international inputs. And we hope that they will clearly provide high specific and a strong foundation for future APS research. I would like to acknowledge all colleagues involved in every stages of these international efforts, especially my colleagues Dorika Khan and Meda Barbaya. Thank you very much for your attention. Thank you.